Welcome back to the deep dive. If you're a future clinician, or really just anyone navigating the complex world of healthcare, you know that pain is, well, it's the universal language of distress.
It absolutely is.
Today we are undertaking an intense and I think an immensely important deep dive into Chapter 8 of Davidson's medicine, focusing on pain and palliative care.
A huge topic.
Huge. And our mission today is explicitly tailored for you, the medical student in your early years. We're not just going to summarize a chapter.
No.
We're building conceptual anchors, these powerful mental models, and some clear decision algorithms that will help you not just understand the mechanisms of pain, but crucially to recall the foundations of managing chronic syndromes and, of course, the principles of total care in palliative settings.
I think this deep dive is non-negotiable for clinical success. Just think about your future practice for a second.
Okay.
Pain, in some form, is likely the single most common symptom you are ever going to encounter. So we're moving past the basic anatomy you studied last semester.
Right, the simple wiring diagrams.
Exactly. We're focusing instead on the why. Why does acute pain become chronic? How does the whole system get, for lack of a better word, hijacked? We'll connect the molecular basis of sensitization directly to the complete psychosocial context that really defines a patient's suffering.
And that's the core challenge, isn't it? So we'll be covering the formal definition of pain, we'll trace the functional anatomy of the pain highway, we'll examine the critical concept of sensitization,
Which is key.
and then detail the necessary multimodal strategies for chronic pain management, and finally establish the foundations of total patient care in the palliative setting. We really want you to walk away seeing pain management not as just a simple prescription, but as a comprehensive, holistic strategy.
That's the goal.
Okay, let's unpack this crucial first step, defining pain. The source gives us that classic, profound definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage.
And that's the revolutionary part right there. The integration of sensory and emotional, it's mandated by the very definition. For students, the first thing you absolutely must internalize is the functional difference between acute and chronic pain. Acute pain is protective. It's an evolutionary necessity.
It's the body's essential alarm system, direct, immediate.
It tells you to get your hand off the hot stove or to immobilize a broken limb. It serves a very clear, very useful protective function.
But chronic pain is a different beast entirely.
It's a completely different beast. That alarm system is fundamentally broken. It serves no useful function, but it just keeps ringing and ringing. It becomes a disease state in and of itself.
And it causes immense distress, suffering, and this massive, often invisible societal impact, in terms of disability and economic burden.
Exactly. It's huge.
So when we talk about chronic pain, we have to immediately discard the simplistic idea of a physical signal traveling cleanly from an injury up to the brain.
It's never that simple. The signal is profoundly modulated.
Okay, so let's introduce our first major conceptual model for today. Let's call it the pain filter, or more formally, the biopsychosocial model.
This model is your framework. It's the lens through which you should view every chronic pain patient. The core, the bio layer, that's the pure sensory input, the actual physical damage, the inflammation, the nerve anatomy, even your genetics.
The raw data.
The raw data.
Yeah.
But that signal has to pass through multiple, really subjective layers of context before it registers as what we call pain in your consciousness.
And it seems like these layers are where clinical intervention can often have the most success. So what's that immediate layer surrounding the core biological input?
That's cognition. This is all about a patient's beliefs about their pain. Are they practicing what we call catastrophizing?
Believing the absolute worst case scenario is always just around the corner.
Yes, that this is irreversible, it's the end of their life as they know it. Or are they moving towards acceptance, which doesn't mean giving up. It means understanding that while the pain may be present, it doesn't have to control every single decision.
So if a patient truly believes that any movement is going to cause permanent spinal cord damage,
that belief itself drastically amplifies the pain signal. It's a powerful modulator.
and that cognitive layer is, I imagine, intrinsically linked to the next one, affect and emotional state. So we're talking about things like mood, anxiety, depression.
And critically, the patient's sense of self-efficacy.
Explain that. What is self-efficacy?
That's huge. It's about how much control they feel they have over their own symptoms and their life. If they feel helpless, anxious, trapped, that emotional state acts as a powerful amplifier. It boosts the sensory input that's passing through the filter. Low mood and anxiety aren't just comorbidities, They are core components of the pain experience itself.
Then we zoom out even further to the macro layers, social and cultural factors. These are the determinants outside the individual's body.
Right. Socioeconomics, family support, religious or cultural beliefs about illness and suffering, access to healthcare, to good food. They all shape pain perception.
Can you give us an example?
Sure. Imagine two patients with the exact same degenerative disc disease. You can see it on the MR. It's identical.
Oh,
One is financially secure, they're retired, they have a strong, supportive spouse who helps out.
okay.
The other is a single parent working two physically demanding jobs, facing eviction, and is deeply worried about feeding their children. Their actual lived experiences of pain, even with identical scans, will be fundamentally clinically different because of that social filter.
That is such a critical point for students to grasp. And the final outermost layer of the filter.
That's illness and pain behavior. This includes the underlying disease, of course, but also the behavioral responses. And a big one is fear avoidance.
Fear avoidance.
This is when a patient stops doing activities they associate with pain. So they stop walking, they stop socializing. This leads to rapid deconditioning, muscle atrophy, and eventually worse functional disability. It feeds the cycle right back into the bio layer.
Wow. So the major key takeaway here seems fundamental for clinical practice. You cannot successfully treat chronic pain by just focusing on that bio layer.
You can't. You can't just treat the tissue damage or the nerve lesion. Successful long-term management demands that you fully assess and integrate the psycho and social components. You have to prioritize function and quality of life over simply reducing a number on a pain scale.
Because if you ignore those outer layers,
You're treating an incomplete picture. And you will find that your potent pharmacological interventions, they'll often fail in the long term. And that leads to patient dissatisfaction and, dangerous medication escalation.
So before we move on to the actual wiring, let's just pause on that complexity. It's a really important concept, a little thought experiment for you listening.
Okay.
If you are preparing to see a new patient with chronic back pain, what's the most important piece of information you need from them? Is it the exact location of the disc herniation on their MRI, or is it their belief about why they can't walk across the room?
If you can't immediately answer why the latter might be more critical for their long-term prognosis, just take a moment. It's really worth rewinding and re-listening to those layers of the pain filter.
Okay, now we get into the functional anatomy. We're going to trace the pain signal from the periphery where it's detected all the way up the spinal cord to the brain. We're mapping out the pain highway.
Right. The journey begins with the sensory neurons, what we call the primary afferent neurons. These are the cables that connect the skin, muscles, and our internal organs to the spinal cord.
And they have a few components.
They do. You have the nerve endings out in the periphery acting as detectors, the cell body, which sits safely in a little cluster called the dorsal root ganglion, and then the central termination, which is the synapse in the dorsal horn of the spinal cord.
And the actual detectors in the periphery, what are those called?
Those are the nociceptors. They're basically just bare nerve endings that get activated by inflammatory mediators, things like bradykinin, prostaglandins, or even just changes in pH from the tissue damage.
So once they're activated, they generate an action potential. But the speed and, I guess, the quality of that signal depends entirely on the type of wire it's traveling on.
And this is where we need to anchor our next concept, the speed limit, which is all about the different nerve fiber types. The difference between that immediate sharp pain and a persistent dull ache is purely a matter of the fiber type carrying the signal.
I know we have the big, fast myelinated fibers, like A-alpha for proprioception and A-beta for light touch. But for pain, we're focused on two other classes.
Exactly. First, the A-delta fibers. These are small, but they're still myelinated, which makes them fast conductors. They transmit that fast, initial, well-localized, sharp pain.
The ouch signal.
The ouch signal, the immediate warning that says, danger, stop now. They also handle thermal sensation. They're like the emergency broadband connection, giving sharp, precise information.
And you contrast that with the C fibers.
Yes, these are unmyelinated, which makes their conduction velocity much, much slower. They carry the signal for diffuse, poorly localized, slow, persistent pain. That throbbing ache that just lingers long after the initial sharp injury.
The old dial-up line.
The old dial-up line. That's a perfect analogy. And understanding this difference is critical for figuring out why some medications might target one type of pain over another.
So the signal, whether it's fast or slow, arrives at the spinal cord and hits the dorsal horn synapse. And you mentioned this is the first major processing center, a crucial site for modulation.
I called it the spinal cord's volume control. And that's exactly what it is. This synapse is a battlefield of neurotransmitters.
A battlefield. I like that.
On one side, you have your inhibitory forces, the neurological brakes. These are primarily glycine and GABA. Their job is to reduce the transmission of the pain signal up the tract, to quiet it down.
And on the other side,
Accelerators. The accelerators, yes. The powerful excitatory forces, that's primarily glutamate, and then neuropeptides like substance P and CGRP.
so the intensity of the signal that actually goes up to the brain isn't just a function of the input from the periphery, but it's the balance at that synapse between the spinal cord's own brakes and accelerators.
That's right. And we have to remember our own body's built-in inhibitory system.
Yeah.
Our own opioids, the endorphins, they bind to mu opioid receptors, or MOPs, right there in the dorsal horn, and they apply a very powerful natural brake to transmission.
Okay, so once that signal gets past the dorsal horn, it ascends up to the thalamus and then gets distributed across the cortex, forming what the text calls the pain neuromatrix. This isn't just sensory processing, is it?
No, the neuromatrix is the integrated experience of pain. This is why pain is emotional. It's why it's cognitive. The signal involves the sensory cortex, which tells you where it hurts, but it also goes to the amygdala.
The fear and emotion center.
Exactly. And the hypothalamus for the autonomic response, the sweating, the racing heart, and of course the cerebral cortex for the cognitive interpretation, for the meaning we assign to the pain. The brain doesn't just passively receive the signal, it actively interprets and critically regulates it.
Let's talk about that regulation, the descending system.
Right. Under normal healthy conditions, the brainstem, specifically areas called the periaqueductal gray matter, or PEG, and the rostral ventromedial medulla, the RVM exerts what we call descending inhibition.
It's the brain's handbrake.
Perfect way to put it. It actively sends signals down the spinal cord to reduce peripheral input, especially via serotonergic and noradrenergic pathways. And abnormalities in this top-down regulatory system are increasingly thought to be a core driver of conditions like chronic widespread pain.
We need to give a moment to the players that are often overlooked in this story, the glial cells.
Yes. Their role is gaining immense significance. In chronic pain states, these non-neuronal cells like astrocytes and microglial cells, they become activated. They essentially act like immune cells within the central nervous system.
What do?
They release pro-inflammatory cytokines, creating what is essentially an inflamed CNS environment. They also mess with how glutamate is cleared from the synapse, which directly contributes to neuronal hyperexcitability. This discovery has opened up really exciting new therapeutic targets, focusing not just on the neurons, but on the immune-like responses of these supporting cells.
And this takes us directly to the absolute core pathology of chronicity, sensitization, which we're anchoring as the volume knob turning up.
This is neuronal plasticity gone wrong. The nervous system is designed to adapt, but in chronic states, these adaptations are detrimental. They become prolonged, semi-permanent.
So let's look at the two stages. First, peripheral sensitization. This is happening locally, right at the site of the injury.
Right. Inflammation releases those mediators we talked about, bradykinin, prostaglandins. They bind to receptors on the nociceptors, and this dramatically reduces the activation threshold of that sensory neuron.
So what does that mean in practical terms?
It means a light touch or a mild stimulus that shouldn't cause pain now generates a full action potential. The volume knob is turned way up peripherally, and that floods the spinal cord with an overwhelming amount of signal.
And that sustained flood from the periphery triggers the most critical change of all, central sensitization. This is a mechanism that locks the acute pain signal into a chronic, self-perpetuating loop.
This happens at the dorsal horn. It is driven by the sustained, massive release of glutamate from that primary afferent neuron. Now, normally, the crucial NMDA receptor complex is blocked by inhibitory magnesium ions. It's like a plug in a drain.
Okay.
But when enough glutamate is released, it overcomes those magnesium ions. It literally kicks the plug out, opening up the NMDA receptor.
And what's the clinical outcome of activating this NMDA cascade? What does the patient feel?
It leads to prolonged somatosensory modifications. This amplification is what causes two phenomena that are essential for you to recognize in the clinic. First, amplified pain responses, which we call hyperalgesia. And second, and this is crucial, after discharge.
After discharge.
It means the neuron just keeps firing, and the patient feels persistent, continuous pain even after the noxious stimulus has been completely removed. In neuropathic pain, this chronic activity can also destroy the inhibitory interneurons, which just potentiates the pain even further.
It's a vicious cycle. We should also just anchor the fact that our individual experience of pain is profoundly influenced by our genetics.
Massively. We estimate the heritability of chronic widespread pain is somewhere between 30 and 50%. And while the general variance is complex, some rare syndromes really illuminate the underlying biology.
Like what?
Well, think of single gene mutations that affect the sodium ion channel SCN9A, also known as NaV1.7. A loss-of-function mutation causes a complete inability to feel pain. A gain-of-function mutation, on the other hand, causes severe, unrelenting burning pain.
Wow.
This tells us that when we use pharmacological agents that target sodium channels, we're tapping into these fundamental genetically variable mechanisms.
It's important to pause here because that NMDA cascade is the single most critical mechanism for understanding chronic pain therapy. If you're going to treat the chronic state, you absolutely have to find a way to interrupt that process.
So here's the reflective challenge for you. If a patient reports pain that flares dramatically in response to a mild, non-painful stimulus like clothes brushing their skin, allodynia, and they describe pain that persists for hours after the actual mechanical stress is stopped, that's after discharge, which excitatory neurotransmitter pathway is driving this central sensitization.
And if you can't recall the specific ion that usually blocks that key receptor, it's really worth rewinding to review that activation cascade. It's that important.
It is.
Now we transition that technical knowledge into clinical application. When a chronic pain patient walks into your clinic, the diagnostic workup shifts fundamentally away from just finding a single structural cause.
Absolutely. Especially for syndromes like fibromyalgia or complex regional pain syndrome or CRPS, the sources make it clear that imaging and labs are often completely negative. The diagnosis is clinical. It's based on history and exclusion.
Which is why the goals of management are so function-focused. We aim to educate the patient, promote self-management, optimize function, enhance quality of life, and then finally, control pain.
Notice the order there. The emphasis is on function, not just chasing a 0 on a pain score.
And to achieve those goals, we have to execute a meticulous biopsychosocial assessment. And the sources emphasize this is time-consuming, but it is absolutely essential for improving the long-term prognosis.
The clinical history has to be precise. We need the duration, the location mapped out on a body chart, and a really detailed character of the pain. Is it dull? Is it sharp? Or is it that burning electrical sensation that just screams neuropathic pain?
And you have to specifically ask about associated features like allodynia, paresthesia pins and needles, or even something as strange as formication, the sensation of insects crawling on the skin.
Those are powerful clues that the central nervous system has become dysregulated. It's also why you must rigorously document the interference with daily life. How is it affecting their sleep, their work, their relationships?
And crucially, we have to explore the patient's beliefs and expectations. Don't ever assume they understand their disease.
You have to ask directly, what do you believe is causing your pain right now? And what do you expect this treatment will achieve for you? If their expectation is a complete cure for a problem that's been there for 10 years, you have to start managing that expectation on day one to prevent what they will perceive as treatment failure.
And of course, a thorough psychological screening. Mood assessment, and if low mood is detected, a careful suicide risk assessment alongside a history of any substance misuse.
All of it is part of the picture.
Moving to the physical exam, let's talk about specialized tools. Quantitative sensory testing, or QST, it's invaluable for assessing small fiber function right there at the bedside.
And you don't need fancy, expensive machines for this. Simple clinical techniques are essential. Light touch, using a piece of cotton wool, helps you identify allodynia.
Pain from a non-painful stimulus.
Exactly. Using a sharp pinprick, you test for mechanical hyperalgesia, which is an exaggerated pain response. And then thermal rollers, or even a cold tuning fork, can test for stomal sensation abnormalities. The key is you must compare the affected area to an unaffected area on their body to quantify the abnormality.
Okay, regarding advanced investigations, what should a student know about ordering an MRI for chronic pain?
MRI is valuable, but only for focal pain that aligns perfectly with a nerve root or a peripheral nerve distribution, a clear mechanical problem. It is rarely helpful in chronic widespread pain because the pathology is often functional or central, not structural.
And nerve conduction studies.
They're great for assessing large fiber damage, but they poorly examine the small fiber neuropathies that are so often involved in chronic pain.
So if the imaging is unhelpful, how can we definitively test if a peripheral nerve is still the primary driver of the pain?
We use diagnostic nerve blocks. Infiltrating a specific nerve with a local anesthetic like 1% lidocaine is a therapeutic test.
So an example.
Say phantom limb pain. If the pain is completely abolished by a successful nerve block, which you'd confirm by checking for motor or sensory paralysis in that nerve's distribution, the signal is still originating peripherally. And that guides your therapy, maybe towards a surgical revision of the stump.
But if the pain remains unchanged after the block,
Then the pain is centrally driven. It's in the brain now, so to speak. And that means peripheral interventions are very unlikely to work.
the need for standardized tracking systems is also paramount. You can't just ask, how's your pain?
No, you have to use validated pain scoring systems. Tools like the brief pain inventory or the visual analog scale track severity. But you also need to assess the impact. Quality of life measures are essential for that. And for screening for neuropathic pain specifically, tools like the DN4 questionnaire help make sure you don't miss that specific diagnosis.
The ultimate key takeaway here seems to be that for chronic widespread pain, your diagnosis is primarily clinical. It's based on the history, careful sensory testing, and the exclusion of other diseases.
That's it. And failure to identify a significant neuropathic component early and relying solely on generic analgesics is just a recipe for treatment failure and, honestly, patient despair.
Right. So once the diagnosis is established, and assuming the underlying cause is incurable, we shift to management. And the core philosophy is multimodal.
A comprehensive, multidisciplinary strategy that targets the entire biopsychosocial spectrum.
And this begins long before you even think about writing a prescription. It starts with supported self-management.
Yes. And the first hurdle here is often gaining the patient's acceptance that complete resolution of the pain may not be possible. The aim becomes maximizing quality of life despite the ongoing pain.
And the foundation of this is teaching pacing techniques. This is a tricky concept for patients. They often feel they should just push through the pain.
That is the trap. They get into these boom and bust cycles of overactivity, which causes a severe pain flare and days of recovery, which is then followed by underactivity and deconditioning. Pacing breaks this cycle.
How?
By teaching them to spread activity throughout the day, to plan rest breaks before the pain flares up, and to maintain a graded, steady level of activity. We also use relaxation, mindfulness, and, crucially, having a preemptive plan for when the pain inevitably spikes.
The evidence for physical therapies is also really strong, specifically in countering that fear avoidance cycle we talked about.
Absolutely. If the patient avoids movement because they associate it with pain, they decondition. That loss of muscle strength and function then exacerbates the pain further. Graded, tailored exercise is the most effective antidote.
And that can be land-based like yoga or walking.
Or water-based,
Right.
like hydrotherapy. The goal isn't just to strengthen the body, but to retrain the brain to dissociate movement from the sensation of harm.
Okay, now let's talk about the pharmacological arsenal. Given the limited long-term evidence for many single analgesics, why is multimodal therapy considered the gold standard?
Because it's a rational mechanism-based approach. Remember the pain highway we mapped out? We combined different drug classes to target multiple points along that highway,
So you might block peripheral sodium channels.
while also inhibiting central glutamate release and at the same time boosting the brain's own descending inhibitory pathways. By combining drugs, you can use lower doses of each, which significantly reduces the side effect burden compared to just cranking up a single drug to its maximum dose.
The genetic variability in how we metabolize drugs is also a huge factor here.
It forces us to individualize therapy. We know genetic variability in enzymes like CYP2D6 determines how quickly patients metabolize weak opioids like codeine or tramadol into their active forms.
So if a patient is a poor metabolizer,
That drug is basically inert for them. It does nothing. If they're a rapid metabolizer, they can experience toxicity very quickly on a standard dose. This variance is the rationale for why you may need to try different agents even within the same class if the first one fails.
let's look at the specific agents, starting with the non-opioids, paracetamol or acetaminophen.
It's the starting point for mild pain, although its exact mechanism is still a bit fuzzy. We think it involves weak COX inhibition and maybe activating those serotonergic pathways. But here's the crucial clinical reality.
What's that?
Robust evidence shows it offers very little benefit over a placebo for many chronic musculoskeletal disorders, like osteoarthritis, when it's used long-term. And students must be aware of the risk of acute liver failure. You have to use extreme caution in older adults, or anyone weighing less than 50 kilograms, even at the recommended maximum dose.
NSAIDs, on the other hand, are excellent for inflammatory pain, but carry significant long-term risks.
They are critical for conditions where a clear inflammatory component rheumatoid arthritis, or the bone pain you see in cancer metastases. However, their use in chronic, non-inflammatory pain is severely limited by their cardiovascular, GI, and renal toxicity risk. So we typically use them only for short periods or for specific flares.
What if the pain is very localized? Can we use something topically?
Yes, topical analgesics are fantastic because they minimize systemic exposure. The capsaicin 8% patch is a great example. It works by acting on the TRPV1 ion channel of the C fibers.
It causes an initial strong heat sensation, right?
It does, but that overwhelming stimulation leads to desensitization and a temporary localized reduction in nerve fiber density. It's almost like a pharmacological ablation, and the relief can last up to 12 weeks.
And the lidocaine patch?
The lidocaine 5% patch works differently. It blocks voltage-gated sodium channels right there in the sensory neurons, physically reducing the input to the spinal cord. It can take 4 to 6 weeks for maximum benefit, but it's a key tool for focal neuropathic pain.
Now, for the agents that target that sensitized central nervous system, the anti-neuropathic agents. These are the drugs that fight that NMDA cascade or bolster descending inhibition.
These are your first-line agents for neuropathic pain. They do not provide immediate relief. They require weeks of slow-dose titration to establish a steady state. We typically start with either the SNRIs, like duloxetine, or the TCAs, like amitriptyline or nortriptyline.
And their mechanism is elegant. They primarily increase the availability of serotonin and noradrenaline in the spinal cord, which enhances that natural descending inhibitory brake system we talked about earlier.
Exactly. The second-line agents are the antiepileptics, gabapentin or pregabalin. These work by inhibiting calcium channels on the primary afferent neurons.
Which does what?
It reduces the presynaptic release of excitatory neurotransmitters, primarily glutamate, so they dampen the signal before it can trigger that NMDA cascade.
The sources highlight a really serious caution regarding those antiepileptics, though.
Yes. Despite their effectiveness, there is increasing global concern regarding their potential for abuse and their growing association with drug-related deaths, especially when combined with opioids. So when you escalate to these agents, you must remember the potential risks alongside the benefits and ensure really robust monitoring.
This brings us to probably the most difficult area of chronic pain management: opioid analgesics in chronic non-cancer pain.
This is a challenging conversation for every clinician. Strong opioid use surged globally based on, frankly, minimal evidence. The reality is that there is very limited evidence of benefit for strong opioids in chronic non-cancer conditions like low back pain or osteoarthritis, not even in the short to medium term.
And long-term studies.
Long-term studies actually show worse function, worse pain scores, likely due to something called opioid-induced hyperalgesia, and of course, significant side effects.
And the risk profile scales very rapidly with the dose. What are the key harm thresholds we need to anchor?
Increased harm, and we're talking about addiction, fractures, hormonal dysfunction, and overdose, is clearly associated with doses greater than 50 milligram morphine equivalents per day, or MME. And the risk increases sharply again at doses over 90 milligram MME per day.
So what's the strategic takeaway for a future clinician?
It's simple. Strong opioids should only ever be considered for short to medium-term use in highly selected patients, always accompanied by clear, measurable goals for function, not just pain reduction, and with definite, agreed-upon stopping rules if those functional goals are not being met.
So if the medication approach is multimodal, what about the complementary therapies?
Psychological therapies are critical for managing the psycho component of the biopsychosocial model. CBT, or cognitive behavioral therapy, focuses on restructuring those catastrophic thoughts. And ACT, acceptance and commitment therapy, is also highly effective. It uses mindfulness to help the patient accept the presence of pain while still committing to living a life that aligns with their values.
And what about stimulation therapy?
Acupuncture, which we think works via endogenous opioid release, and 10NS units are both viable options, especially for muscular components. For severe refractory neuropathic conditions like CRPS, neuromodulation via spinal cord stimulation is a highly effective, albeit invasive, specialist intervention that we use when all other modalities have failed.
This complex array of choices requires constant integration. So here's a check-in for you. If you've successfully started a patient on a first-line agent, say a TCA, and they are still experiencing breakthrough neuropathic flares, what logical second agent would you add, and why would you avoid simply doubling that TCA dose?
Think about the goal of multimodal therapy. You want to target different pathways. If you need a hint, think about the primary mechanism of the second-line anti-epileptic agents we just discussed.
Let's focus now on 3 specific syndromes that represent major clinical challenges. The first, which is really an umbrella term for many severe chronic pains, is neuropathic pain.
This is pain associated specifically with a lesion or a disease of the somatosensory nervous system. And the numbers are grim. About 17% of those affected rate their quality of life as being worse than death. It's highly disabling, and its complex presentation just reflects the chaotic underlying mechanism of central sensitization.
Recognizing it clinically is key.
Absolutely. You look for spontaneous pain, but also those positive sensory disturbances like allodynia or hyperalgesia, and the negative sensory disturbances like numbness or loss of sensation.
And the management algorithm confirms our multimodal strategy.
It does. First line is an SNRI, a TCA, or gabapentin pregabalin. Second line involves the topical agents or tramadol. Strong opioids are reserved for third line and should be used with extreme caution. This just reinforces the principle that you must use specific agents that target the CNS volume knob.
Next, complex regional pain syndrome, or CRPS. This is rare, but devastating.
CRPS is a form of neuropathic pain that usually affects a limb. It used to be known as reflex sympathetic dystrophy. It's often linked to autonomic nervous system dysfunction, and it leads to severe pain that is wildly disproportionate to the original injury.
And there are two types.
Yes. Type 1 is precipitated by trauma, but lacks definitive nerve damage. Type 2 is clearly associated with a peripheral nerve lesion.
How do we diagnose it clinically?
The diagnosis relies on the Budapest criteria. You need signs and symptoms across specific categories. Sensory, like hyperalgesia,
Yeah.
vasomotor, like temperature or skin color changes, pseudomotor edema, like sweating or swelling, and motor-trophic changes, like weakness or hair and nail changes.
And management.
Early aggressive management is crucial. It combines the standard neuropathic drugs with specialized rehabilitation like graded motor imagery and desensitization techniques.
Finally, the very common post-amputation pain, phantom limb pain.
This is the phenomenon of pain being felt in the absent limb. It's fundamentally a neuropathic problem that reflects this massive central reorganization in the somatosensory cortex following the amputation.
So management is a combination of anti-neuropathic medications.
Guided by diagnostic nerve blocks to rule out a residual peripheral nerve issue in the stump, and specialized non-pharmacological rehabilitation techniques like mirror visual feedback, which can be incredibly effective at retraining the brain.
And we should just anchor the concept of chronic widespread pain, or CWP, which often occurs with fatigue and irritable bowel syndrome. Fibromyalgia is a common subtype of this.
Yes, and it's clinically defined by myofascial trigger points and severe sleep disturbance, which just emphasizes again that this is essentially mediated sensitization problem, not a purely peripheral muscular one.
We transition now to palliative care, a field that is so often mistakenly conflated with end-of-life care. And they are distinct. Students must understand the difference.
Absolutely. Palliative care is the active, total, supportive care for patients with an incurable disease. The focus is on managing symptoms, physical, psychological, social, and spiritual needs.
And crucially, it should be delivered at any stage of the illness.
At any stage. It can be concurrent with optimal disease-control treatments like chemotherapy or dialysis. It is not just for the very end of life.
End-of-life care, by contrast, is reserved for patients with far advanced, rapidly progressive disease that will soon prove fatal. And here, the focus shifts entirely.
It does. We prioritize quality of life and comfort over procedures aimed at prolonging life.
To frame expectations and plan resource allocation, we use our final conceptual model for today.
Trajectories of illness.
This is a really helpful way of thinking. The first is the classic rapid decline, which is typical of many cancers. Patients have relatively good function for a while, and then there's a short, steep, rapid terminal decline.
The second is the erratic intermittent decline. This is common in organ failures like advanced heart failure or COPD. These patients experience periods of stability that are punctuated by acute, severe exacerbations that often land them in the hospital. Managing their symptoms means constantly balancing acute treatments with comfort care, knowing they might recover, but to a new, lower baseline of function.
And the third trajectory, the long functional decline, characterizes frailty and dementia.
This can involve years of poor function, often requiring very high levels of nursing care before a relatively short final phase. Advanced planning and support for the caregivers are absolutely paramount in this trajectory.
In any palliative setting, effective pain management is the cornerstone of quality care. We know up to 2/3 of cancer patients experience moderate to severe pain, often compounded by a neuropathic element.
And the primary failure point here is assessment. The source really stresses avoiding idiosyncratic shortcuts, meaning you must use validated questions. Something as simple as, on a scale of 0 to 10, have you had any pain in the last 24 hours? Tools, like the Edinburgh Pain Assessment Tool, guide you to link specific pain types, like bone pain or neuropathic pain, to tailored management algorithms rather than just reaching for the standard prescription every time.
And the management strategy adheres to the established WHO analgesic ladder.
Yes. Step 1. A non-opioid, like paracetamol or an NSAI, for mild pain. If pain persists or increases, you move to Step 2. You add a weak opioid, like codeine 60 milligram, 4 times a day.
And if the pain is severe at the outset or it's unrelieved by Step 2?
You move immediately to Step 3. You substitute the weak opioid for a strong opioid, with oral morphine being the standard of care.
There is an important clinical caveat regarding that second step, isn't there?
Yes. Evidence, particularly from lower and middle-income countries, shows that it is safe, effective, and often more cost-effective to just skip Step 2 entirely and move straight to a low dose of a Step 3 opioid.
And why is that?
It's driven by the variability and cost associated with the Step 2 agents and the established safety of carefully titrated strong opioids.
Okay, so once a patient is on a strong opioid titration is key. We use immediate-release oral morphine, which takes about 20 minutes to work and lasts for about 4 hours.
We have to establish a regular round-the-clock dose, often every 4 hours. But we also must proactively manage breakthrough pain. These are the intermittent spikes in pain, often related to movement, which we call incident pain.
And there's a standard calculation for the immediate-release breakthrough dose. It's simple and vital.
It is. The breakthrough dose should be 1/6 of the total 24-hour regular dose.
So if the patient is on 120 milligrams of slow-release morphine a day, their IR breakthrough dose would be 20 milligrams taken as needed.
Exactly. And you review their breakthrough usage daily. If they're consistently taking, say, 3 doses of the IR per day, you add that total 60 milligram to the next day's regular dose.
But there's a crucial point about incident pain.
Yes. Breakthrough doses used for incident pain caused solely by movement, like rolling over in bed, are generally not included in the background dose titration. Trying to control that high-intensity movement pain with a high background opioid dose just leads to oversedation when the patient is resting.
We must anticipate and manage opioid-related adverse effects.
Nausea and drowsiness are common initially, but patients usually develop tolerance within a few days. However, tolerance does not develop to constipation or dry mouth.
So what does that mean in practice?
It means every single patient started on an opioid, weak or strong, requires a routine, scheduled prescription for laxatives and meticulous oral care. It's not optional.
What are the signs of opioid toxicity that demand immediate clinical action?
You need to look for signs of central nervous system excitation, vivid dreams, visual hallucinations, confusion, delirium, or myoclonus, which are muscle jerks.
And if you see those...
Toxicity requires urgent reassessment. You have to exclude reversible causes like an infection, and crucially, you must check for renal impairment. If the patient has renal failure, the active opioid metabolites can rapidly build up to toxic levels.
Which necessitates opioid rotation.
Right. Rotation means switching to a different strong opioid, often oxycodone, or agents like fentanyl or buprenorphine, which are preferred in renal failure because they lack those renally excreted active metabolites that cause all the trouble.
That's a key point.
And thankfully, psychological dependence is rare in cancer patients receiving appropriate pain control, though physical dependence withdrawal will occur if the drug is stopped suddenly.
Beyond the opioids, what are the key adjuvant analgesics in cancer pain?
We integrate specific drugs for specific pain types. NSAIDs are crucial for bone metastases and inflammatory pain. Glucocorticoids, like dexamethasone, are powerful tools for pain related to raised intracranial pressure, nerve compression, or pain from a stretched liver capsule.
And of course, the antineuropathics.
Anticonvulsants and TCAs are standard for any neuropathic component of cancer pain.
Palliative care is total care, extending to complex, non-pain symptoms. Let's discuss the highly distressing symptom of breathlessness or dyspnoea.
We always rule out reversible causes, like a pleural effusion. But the non-pharmacological interventions are simple and highly effective. The sensation of cool airflow from a handheld fan, pacing, and tailored exercise.
And what about oxygen?
Oxygen is only indicated if the patient is actually hypoxic. The cool airflow is often just as effective at relieving the sensation of dyspnoea. And crucially, opioids are licensed for the palliation of breathlessness. They act both centrally and peripherally. If anxiety is a dominant component, a benzodiazepine like lorazepam may be added.
We also have to manage nausea and vomiting. The sources emphasize a rational, receptor-based approach for picking an antiemetic.
You have to treat the cause. For example, metabolic issues like hypercalcemia or uremia, they primarily stimulate D2 receptors in the brain's chemoreceptor trigger zone, or CTZ, so you use a D2 blocker like haloperidol.
And if it's gastric irritation?
That stimulates H1 and HE receptors in the vomiting center, so agents like cyclosine are more effective. You have to match the drug to the site of action.
For advanced gastrointestinal obstruction, which is often managed non-surgically in terminal disease, the symptoms can be just overwhelming.
They can. Here, we rely on parenteral drugs. Glucocorticoids can reduce edema and inflammation, potentially shortening an obstructive episode. And somatostatin analogs like octreotide are key.
Why?
Because they drastically reduce the volume of intestinal secretions. This reduces large volume vomiting and colic, making the patient much more comfortable.
Finally, managing the psychological and physical symptoms right near the end. Delirium is extremely common.
It requires urgent management, and you have to distinguish it carefully. Is the patient confused because their pain is uncontrolled, or are they actively delirious? Opioids may improve confusion caused by pain, but they can definitely worsen delirium.
So how do you manage it?
With antipsychotics like low-dose haloperidol, rather than relying solely on benzodiazepines, which can often accelerate confusion and agitation.
And the final phase, death and dying. Communication is paramount.
Open, honest, and gentle communication with the patient and their family is essential. Students must learn to recognize the signs of actively dying, being bedbound, semi-comatose, unable to swallow tablets, only taking small sips of fluid. This usually suggests death is likely within about 48 hours.
And at this stage, there's a significant shift in management.
Everything changes. We stop non-essential medications, statins, antihypertensives, and all unnecessary investigations. Parenteral hydration is often withheld because it can worsen distressing respiratory secretions. Instead, meticulous oral care is prioritized to ensure comfort. And of course, all decisions are guided by ethical considerations around capacity and advance directives, ensuring the patient's wishes remain paramount.
We've covered the entire spectrum, from the molecular wiring of pain to the ethical considerations at the end of life. So, a final check-in, Frenno. If you're starting a patient on step 3 of the WHO ladder, requiring rapid titration of morphine, and they begin developing muscle twitching, hallucinations, and confusion, what is the single most likely pathological contributor you must check for immediately? One that might necessitate a change to fentanyl or buprenorphine.
If you can't recall the renal factor we discussed, it's worth reviewing the section on opioid rotation and toxicity.
We've charted the nervous system's response to injury, anchored the principles of the biopsychosocial filter, detailed the complex mechanisms of central sensitization, and outlined the philosophy and specifics of total care at the end of life.
The depth and complexity of this material should convince you that effective pain and palliative care demands continuous interdisciplinary assessment and truly individualized plans. You must treat the person, integrating their social, psychological, and biological realities.
Never just treat a number on a pain score or rely on a formulaic prescription. So what does this all mean for you as you enter the clinic? The challenge now is to internalize the mechanisms of sensitization, knowing how pain turns chronic via that relentless NMDA cascade, so you can advocate for multimodal therapy from the very beginning. You are now equipped to ask the right questions and pursue the right combination of pharmacological and non-pharmacological interventions to interrupt this deeply rooted process.
And for a final provocative thought, we spent a lot of time discussing how chronic widespread pain can result from abnormalities in top-down, descending inhibition that originates in the brainstem, and how the inflammatory role of glial cells potentiates that central processing.
Right.
So given that many severe chronic pain syndromes are refractory to our standard peripheral and spinal therapies, what might be the logical next cellular or regional target for intervention if research continues to confirm the importance of this central top-down regulation?
So you're saying think about intervening not on the incoming signal,
But on the brain's internal volume control system itself.